ನಮಸ್ಕಾರ. ಇಂದಿನ ನಿಮ್ಮಲ್ಲಿಗೆ ಕನ್ನಡ ಕೂಟ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಿಮಗೆಲ್ಲರಿಗೂ ಸ್ವಾಗತ. ಇಂದು ಟಾಕ್ ಅಬೌಟ್ ಕೋವಿಡ್-19 ಈ ಸರ್ಜನ್ಸ್ ಪರ್ಸ್ಪೆಕ್ಟಿವ್ ಅನ್ನೋದ್ರ ಬಗ್ಗೆ ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಕಿಲೇರ ಅವರು ಮಾತಾಡಲಿದ್ದಾರೆ. ಅವರಿಗೆ ನಮ್ಮ ಕರ್ನಾಟಕ ಸಾಂಸ್ಕೃತಿಕ ಸಂಘ ದಕ್ಷಿಣ ಕ್ಯಾಲಿಫೋರ್ನಿಯಾದ ಪರವಾಗಿ ಹೃತ್ಪೂರ್ವಕವಾದ ಸ್ವಾಗತ. ಇವರನ್ನ ಪರಿಚಯ ಮಾಡಲಿಕ್ಕೆ ಅರವಿಂದ್ ಸ್ವರಾಫ್ ನಮ್ಮದೇ ಸದಸ್ಯರಾದವರು ಬಂದಿದ್ದಾರೆ. ಅವರಿಗೂ ಕೂಡ ಹೃತ್ಪೂರ್ವಕವಾದ ಸ್ವಾಗತ. ಕಾರ್ಯಕ್ರಮ ಪ್ರಾರಂಭ ಮಾಡಲಿಕ್ಕೆ ಮುಂಚೆ ಒಂದೆರಡು ಪ್ರಕಟಣೆಗಳು. ಸೊ ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿರೋ ಹಾಗೆ ಈ ಶನಿವಾರ ಒಂದು ವಿಶೇಷ ಕಾರ್ಯಕ್ರಮ ಇದೆ. ಸೊ ಹಳೆ ನೆನಪು ಹೊಸ ಟೈಪು ಅಂತ ಹೇಳಿ. ಸೊ ಅದ್ರ ಬಗ್ಗೆ ಒಂದು ವಿಡಿಯೋ ನೋಡೋಣ ಈಗ. ಸೊ ಈ ಕಾರ್ಯಕ್ರಮ ಸ್ವಲ್ಪ ವಿಭಿನ್ನವಾಗಿರುತ್ತೆ. ಸಂಸ್ಕೃತಿ ವಿಶೇಷ. ಸೊ ಕೆಲವು ವಿಶೇಷ ಅತಿಥಿಗಳು ಬರ್ತಾ ಇದ್ದಾರೆ, ಮತ್ತೆ ಕೆಲವೊಂದು ವಿಡಿಯೋ ಎಲ್ಲ ಇದೆ. ಸೊ ದಯವಿಟ್ಟು ತಪ್ಪದೆ ನೋಡಿ. ಶನಿವಾರ ಸಂಜೆ 7 ಗಂಟೆಗೆ. ಇದಲ್ಲದೆ ಮತ್ತೊಮ್ಮೆ ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಕಿಲೇರ ಅವರಿಗೆ ಸ್ವಾಗತ, ಅರವಿಂದ್ ಅವ್ರಿಗೂ ಸ್ವಾಗತ, ಮತ್ತೆ ನಮ್ಮ ಕಾರ್ಯಕ್ರಮ ನೋಡ್ತಾ ಇರತಕ್ಕಂಥ ಎಲ್ಲ ಸದಸ್ಯರು ಸ್ನೇಹಿತರಿಗೂ ಕೂಡ ಸ್ವಾಗತ. ಈಗ ಅರವಿಂದ್ ಅವರು ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಕಿಲೇರ ಅವ್ರನ್ನ ಪರಿಚಯ ಮಾಡಿಕೊಡ್ಲಿದ್ದಾರೆ.
ಥ್ಯಾಂಕ್ ಯು ಗುರು. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನನ್ನ ಹೆಸರು ಅರವಿಂದ್ ಅಂತ. ನಾನು ಇವತ್ತು ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಕಿಲೇರ ಅವರ ಕಿರು ಪರಿಚಯ ಮಾಡಿಕೊಡ್ತಾ ಇದ್ದೀನಿ. ಇವರಿಗೆ ನಾನು ಸುಮಾರು ಒಂದು 15 ವರ್ಷದಿಂದ ನನಗೆ ಇವ್ರ ಪರಿಚಯ ಇದೆ. ಇವರು ನಮ್ಮ ನೆರೆಮನೆಯವರು, ಆತ್ಮೀಯ ಸ್ನೇಹಿತರು. ಸಲಿಗೆಯಿಂದ ಆನಂದ್ ಅಂತಲೂ ಕರಿತೀನಿ. ಇವ್ರ ಫುಲ್ ಹೆಸರು ಉತ್ತಯ್ಯ ಆನಂದ್ ಕೊಕ್ಕಿಲೇರ ಅಂತ. ಸೊ ನನಗೆ ಇವ್ರು ಆನಂದ್ ಅಂತಲೇ ಗೊತ್ತು. ಸೊ ಇವರು ಆನಂದ್ ಅವರು ಬೆಂಗಳೂರಿನಲ್ಲಿ ಹುಟ್ಟಿ ಬೆಳೆದು ಬೆಂಗಳೂರಿನಲ್ಲೇ ಎಲ್ಲ ಓದಿದ್ದು. ಸೆಂಟ್ ಜೋಸೆಫ್ಸ್ನಲ್ಲಿ ಅವರು ಪದವಿ ಪೂರ್ವಕ ವಿದ್ಯಾಭ್ಯಾಸ ಮಾಡಿರ್ತಾರೆ. ಅಲ್ಲಿ ಫೀಲ್ಡ್ ಹಾಕಿ ಮತ್ತು NCCಯಲ್ಲಿ ಸಕ್ರಿಯವಾಗಿ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಇವರು 1989 ರಿಪಬ್ಲಿಕ್ ಡೇ ಪೆರೇಡ್ನಲ್ಲಿ ಕೂಡ NCC ಮೂಲಕ ಮಾರ್ಚ್ ಪಾಸ್ಟ್ನಲ್ಲಿ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ನಂತರ BMCಯಲ್ಲಿ ಬ್ಯಾಂಗ್ಳೂರ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನಲ್ಲಿ ಓದಿ ವೈದ್ಯಕೀಯ ವಿದ್ಯಾಭ್ಯಾಸವನ್ನು ಓದಿ 1996ನಲ್ಲಿ ಗ್ರಾಜ್ಯುಯೇಟ್ ಆಗಿದ್ದಾರೆ. ನಂತರ ಉನ್ನತ ವಿದ್ಯಾಭ್ಯಾಸಕ್ಕಾಗಿ ಮೊದಲು ಇಂಗ್ಲೆಂಡ್, ಆಮೇಲೆ US ಬರ್ತಾರೆ. US ಇವರು ಮೌಂಟ್ ಸೈನೈ, ನ್ಯೂಯಾರ್ಕಲ್ಲಿ ಮೌಂಟ್ ಸೈನೈ, ಗತ್ರಿ ಮತ್ತು UMass ಮೆಡಿಕಲ್ ಸೆಂಟರ್ಗಳಲ್ಲಿ ಪದವಿಗಳನ್ನು ಮುಗಿಸಿದ್ದಾರೆ. ಅಲ್ಲಿ ಪದವಿಗಳಾದಮೇಲೆ ನಾರ್ತ್ರಿಡ್ಜ್ ಮೆಡಿಕಲ್ ಹಾಸ್ಪಿಟಲ್ನಲ್ಲಿ ಸರ್ಜನ್ ಆಗಿ ಸೇರ್ತಾರೆ. ಕಳೆದ ಒಂದು 15 ವರ್ಷಗಳಿಂದ ನಾರ್ತ್ರಿಡ್ಜ್ ಹಾಸ್ಪಿಟಲ್ನಲ್ಲಿ ಟ್ರೌಮಾ ಸರ್ಜರಿ ಮತ್ತು ರೊಬಾಟಿಕ್ ಸರ್ಜರಿ, ಜನರಲ್ ಸರ್ಜರಿ ಮಾಡಿ ಹೆಸರುವಾಸಿಯಾಗಿದ್ದಾರೆ. ಈಗ ಇವರು ನಾರ್ತ್ರಿಡ್ಜ್ ಹಾಸ್ಪಿಟಲ್ನಲ್ಲಿ ಸರ್ಜರಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಚೇರ್ ಕೂಡ ಆಗಿದ್ದಾರೆ. ಆಮೇಲೆ ಇವರ ಸ್ಪೆಷಾಲಿಟಿ ಏನಂದರೆ ಡಾವಿಂಚಿ ರೊಬಾಟಿಕ್, ಅಡ್ವಾನ್ಸ್ಡ್ ಮಿನಿಮಲಿ ಇನ್ವೇಸಿವ್ ಜನರಲ್ ಸರ್ಜರಿ ಕೂಡ ಮಾಡ್ತಾರೆ. ಆಮೇಲೆ ಇಡೀ ವ್ಯಾಲಿಗೆ ಇಂಥ ರೊಬಾಟಿಕ್ ಸರ್ಜರಿ ಮಾಡೋದ್ರಲ್ಲಿ ಇವರು ಮುಂಚೂಣಿಯಲ್ಲಿ ಇದ್ದಾರೆ. ಇವರು ನಾನು ಹೇಳ್ದಂಗೆ ಈ ಪೋರ್ಟರಾಂಚಲ್ಲಿ ಅವರ ಧರ್ಮಪತ್ನಿ ಪ್ರತಿಭಾ ಮತ್ತು ಮಕ್ಕಳು ಗೌರವ್ ಮತ್ತು ಪ್ರಣವ್ ಜೊತೆ ನಿವಾಸವಾಗಿದ್ದಾರೆ. ಈಗ ಬನ್ನಿ ಡಾಕ್ಟರ್ ಕೊಕ್ಕಿಲೇರ ಅವರು ಕೋವಿಡ್ ಬಗ್ಗೆ ಏನು ಹೇಳ್ತಾರೆ ಕೇಳೋಣ.
ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಅರವಿಂದ್. ಧನ್ಯವಾದಗಳು. ನನ್ನ ಕನ್ನಡ ನಿಮ್ಮಷ್ಟು ಚೆನ್ನಾಗಿ ಫ್ಲೂಯೆಂಟ್ ಆಗಿ ಇಲ್ಲ. ಸೊ ನಾನು ಈ ಪ್ರೆಸೆಂಟೇಷನ್ ಮುಖ್ಯವಾಗಿ ನಾನು ಸ್ವಲ್ಪ Kannada words ಮಾತ್ರ ತುಂಬಾ English ಮಾತಾಡ್ತೀನಿ because most of my presentation is very technical. Um, I chose this topic mainly because everybody knows about COVID. In fact, I think people out there know about COVID more than I do, and more than the medical professions do, because there's so much information available out there. There's so much information being transferred via social media, WhatsApp, and so when I was asked to give a presentation about COVID, I was asked to talk initially about its treatment, but I thought everybody out there know about the treatment of COVID, and I thought I'll bring a different perspective into the talk. What I thought was I'll talk about the surgeon's perspective. We as surgeons in the hospital have to deal with different kinds of issues when it comes to patients with COVID or patients with any contagious or infectious disease for that matter. So I thought with the new COVID, I thought it's better to talk about the different aspects of COVID from a surgical perspective. And I hope this sheds some light to all the viewers and listeners out there about what COVID is and what it means to be a surgeon and to deal with COVID. So I'm just going to start my presentation. Please let me know if you can't see it. So you all know coronavirus. That's what's causing the whole COVID-19 pandemic. And amazingly, coronavirus is not something new. If some people are used to reading Aztec comics, you will see that coronavirus has been mentioned in one of the Aztec comics many years ago. So we know about the virus. The virus in the medical field has already been there, but it has never caused any problems until 2019 in December when it started the pandemic. So you all know the pandemic is a health crisis of global impact. It has changed the way people are living. It has changed the way medicine is being practiced all over the world. Definitely a new disease, although like I said, we did know about the virus in the past, but we were not 100% certain as to how the virus is going to pan out and what kind of problems it's going to cause until back in 2019 when the pandemic started. And since this is new and since the disease process is new, the approach we're having and the treatment we're having is still evolving. We don't have enough data to give us enough information to do what we're doing. You all may realize when the pandemic started, we just started with treatment with chloroquine. Chloroquine was considered a wonder drug, hydroxychloroquine. But then suddenly that fell out of favor. Plasma exchange was something that we started doing, but that fell out of favor. So many things over the course of the last 2 years has been tried, thought that was the best thing to do, and then it slowly starts falling out of favor. You all know that the transmission of the virus is through aerosolization, droplet particles, mainly respiratory, but it is also seen in other parts of the body also, and that's where it becomes a surgical issue for us also. You all know that immunocompromised people, people with history of cancer, history of diabetes, history of immunocompromised diseases, all are highly vulnerable for the disease. And fortunately, overall, the morbidity and mortality, that is, people who are getting more symptoms and people dying from the disease, is decreasing as we've come across in the last 2 years. Briefly about COVID-19, the incubation period can be up to 14 days. Normally, it's about 3 to 5 days or maybe 7 days. That's when the virus, if a person gets the virus, it takes about a few days for the virus to replicate in their body and be able to transmit the disease or to be able to show symptoms of the disease. And as you all know, COVID can cause multi-organ involvement, and its presentation can vary. And like you've all seen in the recent variants, you've seen that the symptoms could be much less or could be really bad as when you start initially when the virus started spreading, or with the other variants like Delta variants. Most of the times, patients do complain of cough. 50% of patients have a cough, fever in about 43%. Myalgia, meaning body ache, is a common symptom. Headaches can also be present. Patients can present with shortness of breath and sore throat. Amazingly, diarrhea, nausea, and vomiting is also part of it. Abdominal pain, loss of smell, taste can also be seen, and it's seen in about 10% of patients, and not as common as once thought it was. That every person will have something to do with smell or taste. What it does basically is the virus, which is basically a protein. It attaches itself to the enzyme in the human being called the human angiotensin converting enzyme. This enzyme is mainly present in the lung, but it can also be seen in the other parts of the body, like the heart, brain, kidneys, and the gastrointestinal tract, but not in as much quantity as you see it in the lung. And hence, most patients who have the infection present with a lot of lung related issues. It causes progressive inflammation, meaning when there's an injury to a body organ, there is an inflammatory process, and the inflammatory process continues. And because the virus is pretty potent, it can worsen the inflammatory process, and the inflammatory process in turn causes other issues that we see in patients. But what it is for us as surgeons, is the patients present with a lot of atypical symptoms. These are the things that drive surgical consultations for us. Many complain with abdominal pain, even though they have no symptoms of the respiratory issues, but they complain of abdominal pain. They have nausea, they have diarrhea. So these are the things that they come with to the hospital, and we end up getting surgical consultations for these patients because the ER physicians are not sure what's going on with this patient, and we end up getting called. There are many variants, as you all know. The Alpha variant was first initially isolated in the United Kingdom, the Beta variant in South Africa, Gamma variant in Japan and Brazil. The Delta variant apparently was initially found in India, and the Omicron variant now, which is the most prevalent, it was in South Africa and Botswana. Briefly, I'm going to touch about treatment because this is not a talk about treatment of COVID. There's so much information out there. It was hard for me to try and put it all together as a brief slide. Like I said, I'm not here to tell you about how to treat COVID. In fact, most of the people out there know what the treatments are available for COVID. So I'm not going to go in detail, but treatment obviously differs between what is done at home versus what is done in hospitalized patients. And like I mentioned earlier, most treatments are evolving. Even now, we are not 100% certain as to what we're doing. Is it scientifically right? But we've seen anecdotal events. We've seen, based on what we're using and based on the mechanism of action of these drugs, we're hoping that these are the drugs that really help with the virus. Hopefully in the next year or so, we should be able to see better data to support the treatments that we are providing. For non-specific symptoms, mostly it is symptomatic: fever, cough. These are all symptomatic treatments that you give for patients. But when it comes to viral specific treatments, the antiviral medications are the most effective. There are emergency use authorization medications that are currently approved by the FDA. That's nirmatrelvir and ritonavir. But they are difficult to get, and they're usually given in the hospitals. They're not available outside. And obviously, monoclonal antibodies. Based on my hospital's talk with the intensive care unit people, we don't use that as much unless the patients are very, very sick. We use them, but otherwise we are really not using even monoclonal antibodies. The drug that we are commonly using, though, is the remdesivir. in the hospital. So it's quite common. We see that in the hospital, and we're using it as much as we can. The alternative to that for patients who are at home is the molnupiravir oral medications. It's a 5-day course, and it's been shown to decrease the severity of symptoms. So that is one of the drugs that we're using. So based on what I've read, these are the different medications that are being used to treat the COVID as of now. And obviously the treatment differs. There are other medications that people use. They use steroids, are also being used. Antithrombotic medications that to prevent clots are also used. So those are other adjuncts, and the variety of multivitamins in different dosages are being used with really no data-driven. It's not, that is not data-driven, but it's being used in the hopes that it's working. But the most important thing is prevention. Obviously, prevention is better than cure, and the vaccines are available. And I hope all have taken your vaccines. So this was the latest data I saw 2 days ago. About 363 million people have the virus. 5.6 million people have died from the pandemic, and about 287 million have recovered from the infection. Daily new cases, obviously you've noticed there's a great spike in the new cases that we've seen, starting from December 22nd to January 26th. We've seen a really high spike. I never thought I'd see cases written in millions. This graph is actually in millions. I never thought I'll see this slide, but unfortunately that is the truth, and that's what's happening right now. And daily deaths, obviously, compared to a year ago, the daily death has decreased, and it's great to see that. I think it's two things. One is the virulence of the virus. That means how potent the virus is. That is decreased, and also the treatments are slightly getting better. Plus the vaccinations has really helped in trying to decrease the number of daily deaths that we're seeing from this pandemic. So what are the challenges we have in surgery? I mean, the challenges are many, but in surgery, we have the first challenge we have are surgical patients. The second challenge we have is the surgical workforce. When we talk about surgical patients, we talk about how much we can provide them with surgery. Do we need to provide them surgery? And how can we screen these patients to make sure that the patients do get the care they need, but in a particular time frame? And obviously the surgical workforce, we need to make sure the staff are protected. We all need to have our personal protection equipment. We have to get new personnel trained because people are getting sick, they leave, and we need to get more people. So quick training of personnel is needed. Quick testing of them is needed. And the surgical training obviously is taken a big hit in the way of the residents being affected who are currently under training. So I'll briefly talk about that. And then the surgical process, mainly how do we operate on a patient? How do we provide the surgical care that the patient needs, having known what the disease is and having known how it works? So that's something that we are always learning as we go every day, and things are changing as we go every day. What do we do with the operating room infrastructure? How is that? How can we cater that to a COVID patient? The operating room availability is, if a COVID patient is already being, if a patient's already being used, is using an operating room, how and when can we use that for another patient who is not COVID positive? So things along those lines. And the most important thing is the technical aspects of surgery, the different things that we do in the surgical room, in the operating room. How can we change that? And how can we make that more in line with what's happening in the world around today and in the surgical field? So with surgical patients, we have a level of prioritization. We prioritize the patients basically if they're emergent patients, patients who need surgery now versus urgent, which can wait for maybe a day till we get the patients tested or till we get the patients stabilized. There are certain patients who need surgery soon, within the next 4 weeks. Patients who have cancer, for example, patients who have heart conditions, for example, who need surgery will be deferred up to four weeks. Certain patients can be deferred up to 3 months, and certain patients can be done afterwards. 3 months, for example, patients who come in with simple problems like gallbladder issues or hernias, we can get them to wait till the pandemic or till the crisis is decreased, till operating rooms are available, and then we can operate on them. And many of them who have long-term issues, chronic hernias, for example, do we need to operate on them when there's a pandemic going? If they can wait. So we have to prioritize these patients, and we have to prioritize the way in which we can approach these patients. We have to screen patients. Like, I'm sure all of you have been screened one place or the other, either in the airport or if you're going to a hospital, or if you're going outdoors to eat. You're screened. You're asked for your vaccination records. They check your temperatures. In the same way we do it, we ask for we give patients questionnaires which contain a lot of questions about COVID. We ask them to answer yes or no, and based on that questionnaire, we can at least have a screen to say, okay, these patients don't have COVID. We check the temperatures. Chest X-ray preoperatively we normally do, and the other thing is the reverse transcriptase PCR test, which you all know it's a little bit cumbersome, but they do yield results, and that really helps us in prioritizing patients. Positive and negative patients are also, and negative patients are also problems. They come with false positives, false negatives, all those things that we need to keep in mind. And the RT-PCR test we usually get within 48 hours of surgery, and that also becomes difficult in that the logistics of trying to get those tests, especially in the days when the home test kits were not available and we have to rely on local testing centers to get it done. We had a tough time trying to get those tests in patients who needed surgery emergently or urgently. So these can be an issue, but this is how at least we try to screen patients who need to undergo surgery. Obviously, everybody is involved in this, so the protection and preservation of the surgical workforce is of utmost importance. We have to make sure that all of the patients who are providing care are always protected. We do have a shortage of people. There's isolation requirements. If patients, providers are going off sick, or many are getting redeployed. One of the other issues we're seeing is many nurses are leaving their jobs and trying to do locum jobs, so that way they get paid more during this time of requirement. So we do have, shortage of people. So we have to protect the staff that we have as much as we can. The other thing is, when it comes to managing a surgical problem, we were told initially to at least manage many of the surgical conditions conservatively. What that means is to try and avoid surgery and try to manage them without surgery. For example, patients coming in with appendicitis. Recently, in the last few years, some papers are out there who have shown that treating patients who come in with appendicitis with antibiotics, you can avoid surgery. So that's one of the things that we do. Patients with gallbladder issues who come in with acute gallbladder problems, we tend to treat them with antibiotics and trying to avoid taking them to the operating room as much as we can. So basically, we were told to try and manage many of the surgical conditions that need surgery by not doing surgery, but by trying some other things, by trying antibiotics, for example. So that's what we were asked to do, and thereby we avoid general anesthesia. So I'll talk to you about anesthesia in the coming slides, but the main reason to avoid anesthesia is to either decrease the morbidity the patients will have to go through. And all this has brought about a big change in the operating room environment for us. And we are trying to do different things that we think might be the right thing to do in order to avoid major damage, both for the hospital systems as well as for the patients. With OR infrastructure, OR has a lot of equipment. You all must have seen a picture of the OR. You all may have been, some of you may have been into the OR. If you notice, there are lots of equipment in the OR. So we're always worried that there's possibility of contamination of the OR equipment. And we have to really use our due diligence to make sure that the contamination is as minimal as possible and is cleaned the best we can. So in our hospital, what we did was we dedicated one operating room only for COVID patients. So that way we are not worried about, trying to disinfect or clean as much as we can, and thereby also using other rooms and infecting the other rooms when patients who are not COVID can have their surgery. So we try to dedicate one room. So basically what happens is 1 or 2 rooms is lost because we were not able to use that for non-COVID patients. So we had to make sure that they all were those rooms were set aside for this. The other thing was the operating rooms normally before COVID used to run on positive pressure systems with or without the laminar flow of air. But with COVID, we were told we need negative pressure ventilation. So we had to modify 1 or 2 of the operating rooms to provide the negative pressure that's needed to suck out the virus as much as we can. But later on, they found that it's not really worth doing that. The positive pressure systems and laminar flow is more than enough to help us in the operating room to treat patients with COVID. So luckily, we didn't have to do that for most of the ORs. That's a lot of time and ORs that are lost, as well as a lot of money involved. So luckily, we didn't have to do that. But we do still dedicate one OR as much as we can for COVID patients. To a point where in our hospital, many of the OR operating room theaters became COVID theaters. Only 1 or 2 were non-COVID theaters. So during a spike in the pandemic, that's what happened. So and it becomes a reverse of what we normally do. While the patient is in the operating room, we tend to try and decrease the amount of times we open the door to the operating room. We, in fact, put a sign outside saying, "Don't open the door." And once the personnel are in the room, they cannot leave and go outside the room. So we have to make sure everything we need is already there in the operating room before we enter the operating room, so that once we are in the room, once the patient's in the room, once the personnel are in the room, we cannot leave and go outside. So what we do is we dedicate one person on the outside of the room who will stay always outside as a runner, an external runner. So if we need anything that's not in the room, that's outside the room, we try to get the external runners to run for us and try to get the stuff that we need to help us with the operating. And there's always something that we will need that's not in the room that'll be kept outside. So we have to have, so one person is dedicated for that. So we lose that one person to do other things that can be done in the operating room. And in the past, if you're doing a long case, the OR scrub techs or the OR circulators in the room would leave because their shift changed or something like that. And they used to leave and go, and the new team used to come and help us with the operating, to continue the operation. But with COVID, and we're trying to keep the personnel in, so people who are once comes into the OR will end up remaining in the OR unless it's way too late and they have to leave and we need to get another team. So we try to keep the same team in the operating room. So that means that many people will be doing overtime and they have to be paid overtime. So that is something that we try and try to do in order to prevent people from going in and out of the room or changing in personnel. So in the past, we used to have lots of nursing students, lots of residents. All of them used to come into the operating room to help to see and get educated with the surgery. We try to decrease that, and that decreases the amount of time people our students can get educated from in surgery. So unfortunately, because of COVID, the education part of that, either for nursing students, for residents, is decreased. What we have seen, we are a level 2 trauma center in our hospital, and what we've seen is some patients who need higher level of care, meaning care that we cannot provide in our hospital, who we need to send to an outside facility. We are having trouble doing that because all the facilities are busy, all the facilities are full, and it's hard to transfer patients. And that impacts patient care because they are not able to get the care they need, the surgical care they need for the problems they have. So that is a bit of a problem, but it's so difficult to explain to patients' families and telling them, look, this is what we have. We cannot do this. We have to send the patient out, but we're not able to find somebody. The other question is, should we do this? Any surgeries that we're going to do, should we do them laparoscopically? Meaning, should we do them with tiny incisions by insufflating a CO2 into the abdomen? Should we do them with tiny incisions, or should we do them open? And I'll talk to you briefly about why that is an issue in the coming slides. But that's always a dilemma for us. Initially, we were told it's good to do them all open, but now with changes in the way we do laparoscopy, we tend to continue doing them laparoscopically with tiny incisions. So that's another thing. Obviously, trauma patients are a little bit different. They all come in with acute injuries, and we have to deal with them no matter what. And many of the trauma patients come in, we deal with them, and we later on find out that they were COVID positive. So this is a risk of exposure. So we try to do universal precautions to all trauma patients, especially when there is a spike in the disease process and the spike in the contagiousness of the disease. In the operating room, to stop from bleeding, we use a lot of coagulated devices. There are lots of devices out there, but we use them. And every time we burn something, there's smoke generated. And there's initial scare whether these devices generating smoke with the virus in them can cause problems in transmission. Lots of other equipment we use, like lasers, we use bone saws, we use something called harmonic scalpels, which generate a lot of smoke. And initially we were told it's best not to use those with the small risk of increased bleeding. But over the course of the last 2 years, that has changed. We are no longer worried about that. But there is a way in which we aspirate all the smoke that's generated. Obviously, we have to wear all our protective gear. In the early part of the pandemic, as you all know, we had shortage of the PPEs. Everybody was scrambling to get PPEs. Fortunately, in the United States, we don't have that problem anymore. We do see it at times when there's high patient load, but fortunately, we don't see that now. We also needed to use other areas like the ICU, like other step-down units were also converted to an ICU, and we had to use that one. And I don't know how many of you have had the chance of wearing PPEs and wearing peppers. I'll show you a short video in the end. It is very uncomfortable. It is a lot of equipment that you're wearing. The part of this is the staff cannot be recognized because they're wearing glasses, they're wearing face masks, they're wearing caps. So all the nurses and or scrub techs have a big name written on the back of their scrubs so that we could recognize them. So it's something simple like that is difficult. And because we wear the peppers, because they're blowing air, we cannot hear one another, and we have to shout for the most times. And because we're all covered everywhere, we don't have a verbal facial communication anymore. We have to talk. We have to let people know what we think and how we feel. So the full protection, personal protective equipment involves obviously the gloves. We double glove all the time when we operate. We use two gloves, visors and goggles, N95s. We use PAPRs that are powered air purifying respirators, and they are luckily now the ones that we get now are small, but many of them, when we first started using them, were very bulky. We had to wear them, and we have to stand and operate sometimes for 3-4 hours wearing them, and it's not easy to do. We have to wear a hat, we have to wear shoe covers. We are really hot inside all of this, but we have to continue doing and operating with this equipment. When it comes to surgery, there are many surgeries that are considered aerosolized procedures, meaning in this procedure, lots of aerosolized products are released into the air. And one of the reasons why all surgeons wear these masks is to prevent inhaling these aerosolized aerosols that are generated from this. Tracheostomy, I'll touch on that in a minute. But tracheostomy, bronchoscopy, where they use a small camera to go into the nose and go into your lungs to look into your airways and look into the lungs. Endoscopy, most people know, is using a camera to go inside the GI tract. Dental procedures and different forms of ventilation, like face masks, high flow oxygen, and CPAP, BiPAP. You've heard of all these things, all these words. They're all different ways of providing high flow oxygen to the patient. And these, because they're not completely air sealed, can generate a lot of aerosols. So we have to be careful about this when it comes to taking care of ourselves and taking care of these patients. Obviously, emergencies, like I told you, in trauma, for example, or let's say heart issues, myocardial infarctions or heart attacks, patients come into the hospital, or let's say head bleeds, patients have bleeding in the head that need urgent care. There's really no time for testing. We consider all of them as COVID positive, especially in a spike during a pandemic, and all of them are treated the same. We continued providing for these patients, but taking full precautions. Like I said, all patients are considered COVID positive until we prove otherwise. We all have to wear PPEs and life-threatening procedures we have to perform. There's no other way that we cannot do life-threatening procedures. We have to do it. So we basically take care to make sure that we're not, we're not exposing ourselves or the people around us when we're doing these emergencies. There are many COVID-related emergencies. One is trying to get an IV line. Patients who are in long-term in the ICU, we cannot always use small IV lines in their wrist or elbows. We have to insert longer access, IV access that can stay for a longer period of time, which will not get get removed. So we have to put central lines, for example, or what's called PICC line. The central lines are placed in bigger veins in the neck or the chest, or peripherally inserted central lines where we can put them in the arm, but it has to go all the way towards the major veins of the neck. This has to be inserted. Patients, initially when the COVID patients had, there was a lot of these blood clots causing decreased blood flow to the legs, for example, and the legs become infarcted, meaning they lose complete blood supply, they become into gangrene, and they will need surgery, and they will be needed to be taken to the operating room. Patients who are in the ICU have high pressure ventilation. They get their pressures are set high so that they can oxygenate, and when we do that, they can get something called a pneumothorax. Part of the lung will burst, and air will escape in between the chest wall and the lungs, and it'll get progressively increased, and that will make the lung collapse. So to prevent that, we have to put tubes in the chest to drain off that air, so that the lungs can re-expand. The lungs can collapse because there's too much secretions inside. It collapses, and we have to do a bronchoscopy, like I told you, go in with the camera into the airways and suck out all these mucus plugging that can happen in the lungs. So we do that also. We have to, patients go into renal failure, we have to do dialysis access. Patients can get abdominal emergencies like ischemia of the gut, meaning lack of blood supply going to the bowel, cholecystitis, for example, inflammation or infection of the gallbladder can occur. And last but not least, CPR needs to be done on patients who don't do so well and their heart stops beating in patients with COVID. Now, why I'm bringing this is I want you to understand that these are not procedures that you would do just like we used to do before. For all these procedures, we have to wear the full bodysuit, the PAPRs and everything, and then we have to do these because quite a few of these procedures are aerosolized procedures. We are exposing ourselves to the patient's airway, which is filled with COVID. So we have to be careful about these patients when we are doing these procedures. With COVID, there is collateral damage, and some of the times we don't think about this, but simple things like decreased training for surgical residents, because when there was COVID spike, all the hospitals will cut down on all elective surgeries. Only emergency surgeries can be done because we have to save protective equipment. We have to save space for COVID patients on the floor. We have to save space for COVID patients in the ICU. So we cannot do any elective cases. And when we don't do elective cases, it means the surgical residents don't get to do elective cases. And so that means the surgical training takes a step back. People never think of this, but in 1 year, if the resident is not able to do at least 50% of the cases that he was supposed to do otherwise, then he has lost that amount of training. So that's something that we need to keep in mind. And thereby, they don't get enough adequate operative numbers to graduate from their surgical residency program. And obviously, there's a decrease in surgical education because all the resources are channeled elsewhere, and there's a decrease in surgical education. There are decrease in courses, didactic lectures are all decreased. But fortunately, there is an increase in online courses and webinars, but it still is not hands-on. It's still not that like you're getting trained to do hands-on. So there's always that collateral damage when it comes to having a spike in a pandemic and spike in COVID. Overcrowding of the hospitals with COVID patients can lead to lack of intervention for patients who really need it as an emergency. We've had patients who have had chest pains who have sat at home because they were scared to come to the hospital. Either one, they were worried they're going to get COVID if they come to the hospital, or two, the hospital is so busy and full that there's no space to take care of them. So patients who have heart attacks at home otherwise could have been saved if they had come to the hospital. Patients who have appendicitis, for example, who have some mild abdominal pain, they sit at home, they don't want to come to the hospital, and then they end up getting perforated appendicitis. Now, what is a simple issue of a small procedure that patients can go home within a day, they are staying in the hospital for a long period of time because there is a complication. So very simple, easily treatable surgical conditions can be deferred and thereby cause problems later on. Apparently, the early estimate was almost 37.6% of cancer surgeries were delayed, and 81% of operations for benign procedures were delayed when the pandemic started. That is sad because many patients really, really need surgery, but they're not able to get surgery because of the pandemic. And it's such a collateral damage that initially no one was thinking about, but later on it did come by to people's attention that this is a problem. And the media started talking about this and all that. So like I mentioned, appendicitis, heart attacks, things like that takes a backseat, and unfortunately we can lose those patients. And when COVID started, there was an initial overall increase in mortality in patients after surgery with COVID. I guess the disease process itself was so bad, and then we are operating on an already sick patient. They were not able to tolerate surgery, and they did pretty poorly. Plus the fact that we didn't know the best way to treat them patients from a lung standpoint, from an intensive care standpoint. We did see a high rate of mortality after surgery, patients dying after surgery. But fortunately, that is decreased significantly because now we know much better as to how to deal with these patients. So it's much better now. And when things get delayed, when the surgeries get delayed, there's always a problem with litigation, and this is an ever ongoing problem. Like I told you, we'll just talk quickly about some special consideration like general anesthesia. There's a high risk of transmission because we are dealing with the airway. We have to place a tube in the airway to connect to the ventilator, and during the placement of the tube, we are exposing ourselves to the airway and thereby to the aerosols. One of the problems with putting a tube and taking it out is the airway goes into spasm, meaning the trachea or the breathing apparatus tends to constrict itself and goes into spasm, and that can be a problem. Putting the tube back again becomes very difficult, and sometimes we could lose patients because of that. So that's something that we need to know about when patients are having general anesthesia and patients have COVID. We use something called rapid sequence intubation, where we decrease the amount of airway exposure. We do it very, very quickly. The anesthesiologists are very good at doing that. They do it very quickly. Older patients have altered physiology, and then COVID has made their lung physiology even worse. And thereby, from an anesthetic standpoint, they have to change the anesthetic gases. They have to change the pressures that they use to provide anesthesia. Patients have poor oxygenation overall. Everybody knows that their saturations decrease. So we have to be cognizant of that. And we always have to be ready that in case the anesthesiologist cannot put a tube to get them on the ventilator, a surgeon should be ready to make an airway, surgical airway, we call it, directly in the throat, so that they can put a tube and then get the patients to breathe. And naturally, there is a circuit that connects the ventilator to the patient, and that circuit will get contaminated. We have to make sure that the filters are working correctly, so that the next patient we're using the same apparatus, there's not a risk of transmission of the disease. Briefly, like I told you, tracheostomy is taking this tube that goes into the mouth, and that's been there for a few days, and we think that the patient cannot come off the ventilator soon. Then we convert it to directly into the neck in this area here, and that's called a tracheostomy. And we as surgeons, we do it, and obviously we are opening up the airway that contains a high concentrations of virus. So we have to be really, really careful when we do patients with tracheostomies. And patients who are on long-term ventilators need this converted. We have to do this in a very timely manner so that patients' airways don't get too damaged by keeping the tube in for long. Like I said, the airway is having high viral particles, so we got to be really, really careful. And we have to do it really quickly because patients cannot lose oxygenation during that time when the exchange of tube takes place. So this can be sometimes detrimental on patients. Everybody knows about endoscopy and colonoscopy. I want to go into great detail into that. Again, we use a lot of gas to insufflate or increase the size of the stomach or the colon to visualize it. We have to be protective. We have to be worried about gases escaping. So we have to be cognizant of the fact that we need to keep the gas trapped in. And like I told you in the past, COVID is present even in the GI tract. So we could be exposed by doing this. So many of the GI procedures we do, we need to be cognizant about it, and we need to try and avoid it if it's really not necessary and does not need to be done, and do only the emergency procedures when it comes to endoscopy and colonoscopy. I briefly told you what is laparoscopy. Laparoscopy is my tiny incisions on the belly. We put what we call trocars, and we use tiny instruments to work inside the belly. Now, when we do this, we do add CO2 inside the belly, and like I told you, the virus is present inside the abdomen, and it can be aerosolized and come out in the open in the operating room. So we need to be cognizant. Once we're done with the procedure, we have to take out all the gas into a filtration system, so that way it doesn't escape into the air. And every time we do an instrument exchange, we lose air, and so we need to be cognizant about that. And there, like I said, there was a big debate about whether these procedures should be done should be avoided with laparoscopy. Should we do it open? But luckily, we've come back to the fact that laparoscopy is always better. Patients recover better, faster. And if we are cognizant of the fact that we need to trap air and keep a closed circuit about the air that we're using, then we should be okay doing this. So we use exhaust filtration systems to help evacuation of the air. And we keep a closed loop of the air circuit, so that way we decrease the amount of exposure. I briefly touched upon surgical smoke earlier. So most of the devices in the operating room do have surgical smoke, so we have to be very, very careful. We do have smoke evacuation systems with a capture velocity of 100 to 150 feet per minute. So we can trap all this air, and we have to make sure that we're using these kind of equipment to prevent the air from spreading into the operating room. Last but not least, cleaning of the OR. Like I mentioned earlier, we always try to keep 1 or 2 operating rooms just for COVID patients. And many times it's not monetarily feasible, because there might be a day when we're not using those ORs when we could actually be using them for other cases. So we do sometimes lose out on that. We have to segregate all the cleaning supplies that go into that room. We use virus disinfectants, like we all know, and then whatever we take out from the patients, with like colon or gallbladder, so whatever we take out from the patients, we have to make sure that they're biological hazards, and people know that they're dealing with a patient with COVID, and they're going to be taking these biological hazards with them. We try to use disposable equipment as much as possible, which adds cost to the operating room expense, but sometimes we have to use them. And sometimes if we have to decontaminate an OR, it takes almost 3 hours to decontaminate the whole OR so it can be used for other surgeries. So some final thoughts before I close. COVID is a deadly disease. We all know that. You all know that. Luckily, the mortality and morbidity is decreasing. We did see higher mortality and morbidity in patients undergoing surgery and acute illness. Fortunately, that is also decreasing. We have to pay attention to hygiene and avoid surgery if at all possible, but don't avoid your consultations with the surgeon. Do see a surgeon if you have any issues, and try not to avoid surgery, but it's a surgeon's discretion to avoid surgery if he can. We try to protect all personnel who are part of the surgical process. And obviously, you all know prevention is better than cure. Please get vaccinated, because that's the only way we can fight this disease. I just want to play a quick video of the operating room and how it sounds. I hope it plays. You can hear a humming sound in the background. That's the PAPRs that we're all wearing. It's a constant sound. I've muted the sound here. All of us are wearing PAPRs. This is when we first started doing surgeries for COVID patients. You may notice that I'm not wearing a N95 because I could not wear an N95 and the PAPRs together because it was suffocating me. So I took the risk of not using it. But this is how the operating room is. We have to be quiet as much as we can. We have to just operate and do our work. And if you see, there are not many people in the operating room. There are just 3 of us in there, and there's a circulating nurse and obviously the anesthesiologist. So before I go, I'd like to dedicate this talk to all the ICU nurses in our hospital. They do a great job of taking care of all the sick patients in the ICU. And I hope I closed on time. Thank you once again to the KCA for providing me this lovely opportunity to talk to you and give you a different perspective of the world of surgery that we have to go through. Thank you very much.
ಧನ್ಯವಾದಗಳು ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಲೇರ್ ಅವರೇ. There are a couple of questions. I'll just open it up. ಒಂದು ನಿಮಿಷ. So, Dharini Dixit ಅವರು ಕೇಳ್ತಾರೆ, what type of test is the most accurate? Are home kits effective?
So at this moment in time, the RT-PCRs, I think, are still the standard that we use for tests. None of the tests provided are 100% accurate. There's always some false positives or false negatives that can always come. Mainly, it's because it's user-driven. Home kits are all user-driven. They have to do it correctly. If they don't do it correctly, then you can always get negative tests. So I think someone else doing the test for you is better than you doing it yourself. When I remember when I went to India, this person did the test. She really put the swab right up, to at the end of my nose. I was telling her, "Are you getting a biopsy of my brain really at this point?" But that is the real right way of doing it. So it's not the question of what kind of test, but it's also depends on how you're actually doing it. That is the thing. So it's hard to say whether home kits are really effective because we won't be able to get data from home kits. It's very difficult to collect the data. People will do the test at home. If it's positive, the world will not know about it except them. So it's hard to predict and hard to state, at least at this present time, to say which is more accurate and whether the home tests are effective. It's very difficult to say.
Okay. So, Deepa Narendra ಅವರು ಕೇಳ್ತಾ ಇದ್ದಾರೆ, which variant is the most dominant now in USA? Is it Omicron or Delta?
I think it's the Omicron right now. It's the Omicron right now. I don't think we are seeing much, but the test that we do is hard to, we don't differentiate between the variants, unfortunately. So it's hard to say which variant the patient has. But I think the way things are going, the wave right now is Omicron. So I think right now we are having the Omicron going.
Okay. Next, what precautions should pregnant mothers should take? Do you advise them vaccines? ಅಂತ ರಂಗೇಶ್ ಗಂಟ್ಸಲ್ಲಿ ಅವರು ಕೇಳ್ತಾ ಇದ್ದಾರೆ.
Pregnant mothers should basically be careful and not get exposed to the virus. That's all I can say. I have had, in the beginning part of the pandemic in our ICUs, we have had pregnant mothers who were on the ventilator in the ICU for a prolonged period of time, but they got better and they went ahead and delivered their babies, and their babies are fine. In fact, one of the OBGYN doctor in my hospital, her daughter itself was pregnant, and she was really sick. We almost thought we were going to lose her to a point, but then she did well. The baby did well. She got, she did well. So fortunately, with pregnancy, I don't think there's a big risk of transmission of the virus to the kids. So at this present time, there's no hard data to state that the kids are affected. Definitely, yes, advise pregnant mothers to take their vaccines because of what I just said. They do advise pregnant mothers to take their vaccines. Yes.
Okay. ಇನ್ನೊಂದು ಪ್ರಶ್ನೆ ಮುದ ಸರಫ್ ಅವ್ರು ಕೇಳ್ತಿದ್ದಾರೆ, have you seen a change in physiology in a COVID positive person versus COVID negative person if they are having same type of surgery?
So the physiology depends on how sick the COVID patients are during surgery. If the patients have decreased lung volume or decreased lung reserve, if the patients have decreased cardiac reserve, obviously their physiology changes. But if they have COVID, but they're asymptomatic, or if I have a patient who is not having COVID, and if we operate on them, we don't see much in the way of difference. If you compare likes for likes, apples to apples. But if you have patients who are sick, like say for example, if I had a patient recently who had severe gallbladder disease. He's recovering from very bad COVID. He's in the rehab unit. He's recovering from very bad COVID. And to take him to the operating room, I had to get cardiology to see him first. I had to get anesthesia to see him, just to make sure everybody is on the same boat when it comes to the physiology of the patient. Obviously, their physiology is decreased. There is a significant change, and I think touched upon it briefly on my general anesthesia, on my slide on general anesthesia. Yes, there is a definite decreased change in the physiology in COVID positive patients.
Okay, then there is one more from Rangesh. What is your advice to seniors in USA who want to visit India to be with their families and grandchildren?
It's a risk all of us are taking when we have to travel. It's hard to say. As long as the seniors are vaccinated, as long as the seniors don't have, immunocompromised disease, as long as the seniors don't have severe other comorbidities, then we have to do what is the best thing to do. Ideally, best not to go, especially when there's a peak of the pandemic. Obviously, this peak will come down. Give it 2 or 3 months, and I think it's best to travel maybe in 2 or 3 months when when this variant also decreases in its peak. But if you have to travel, you have to travel. So just be cognizant, be careful. There's no definite best advice for a question like that, but be careful. That's all I can say.
ಓಕೆ, ಧನ್ಯವಾದಗಳು ಡಾಕ್ಟರ್. ಈಗ ರಾಜೀವ್ ಅವರು ವಂದನಾರ್ಪಣೆ ಮಾಡ್ತಿದ್ದಾರೆ.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಇಷ್ಟೊತ್ತು ಬಹಳಷ್ಟು ಒಳ್ಳೆ ಮಾಹಿತಿಗಳನ್ನ ನಮ್ಗೆ ತಿಳಿಸ್ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಡಾಕ್ಟರ್ ಉತ್ತಯ್ಯ ಕೊಕ್ಕಲೇರ ಅವರಿಗೆ ನಮ್ಮ ಕರ್ನಾಟಕ ಸಾಂಸ್ಕೃತಿಕ ಸಂಘ ದಕ್ಷಿಣ ಕ್ಯಾಲಿಫೋರ್ನಿಯಾದ ಪರವಾಗಿ ಹೃತ್ಪೂರ್ವಕವಾದ ವಂದನೆಗಳು. ಬಹಳ ಒಳ್ಳೆ ಮಾಹಿತಿ. ಎಸ್ಪೆಷಲಿ ಮೆಡಿಕಲ್ ಪ್ರೊಫೆಷನಲ್ಸ್ ಅಲ್ಲಿ ಸೆಲ್ಫ್ಲೆಸ್ ಆಗಿ ಎಲ್ಲರೂ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದಾರೆ 2 ವರ್ಷದಿಂದ ಈ ಕೋವಿಡ್ ಇದರಲ್ಲಿ. ಅವ್ರೆಲ್ಲರಿಗೂ ಹ್ಯಾಟ್ಸ್ ಆಫ್ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದಾರೆ. ಅದೊಂದು ವಿಷಯ. ಹಾಗೆ ಈ ಕಾರ್ಯಕ್ರಮ ನೋಡ್ತಿರೋಂತ ನಮ್ಮ ಎಲ್ಲಾ ಸದಸ್ಯರು ಹಾಗೂ ಫೇಸ್ಬುಕ್ ಬಂಧುಗಳಿಗೂ ವಂದನೆಗಳು ಅಂತ ಹೇಳ್ತಾ, ಅದಲ್ಲದೆ ನಿಮ್ಮನ್ನ ಪರಿಚಯ ಮಾಡಿಕೊಟ್ಟಂತ ನಮ್ಮ ಸಂಘದ ಸದಸ್ಯರಾದ ಅರವಿಂದ್ ಅವ್ರಿಗೂ ವಂದನೆಗಳು ಸಂಘದ ಪರವಾಗಿ. ಹೀಗೆ ಮುಂದಿನ ವಾರ ಇನ್ನೊಂದು ಕಾರ್ಯಕ್ರಮದ ಜೊತೆ ಬರ್ತಾ ಇದೀವಿ. ನಿಮ್ಮಲ್ಲಿಗೆ ಕನ್ನಡ ಕೂಟ ಮುಂದಿನ ಗುರುವಾರ ಸಿಗೋಣ ಅಂತ ಹೇಳ್ತಾ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮ ಇಲ್ಲಿಗೆ ಮುಗಿಸ್ತಾ ಇದೀವಿ. ಎಲ್ರಿಗೂ ಶುಭರಾತ್ರಿ. ನಮಸ್ಕಾರ.